Budding doctors and haematologists. This is Dr. Kiani. Welcome to my channel. Under the hot July sun, a European man in his 40s experiences a blistering skin disease on his hands and neck. He also happens to have a history of hepatitis C, drinks alcohol and smokes cigarettes. Although many diseases have heterogeneous manifestations, this presentation is quite pathognomonic of PCT, or Porphyria cutaneatada, a type of porphyria. Porphyrias are rare disorders of heme biosynthesis that lead to the overproduction of porphyrins or heme precursors, causing neurological symptoms, liver and renal disease, and photocutaneous manifestations. There are a total of 8 porphyrias. Some that cause acute cutaneous symptoms under long-wavelength light, and others that result in neurovisceral symptoms after ingestion of toxins, drugs, and hormonal supplements. Here we will focus on the 2 most common porphyrias, Porphyria cutaneatada or PCT, and AIP, also known as acute intermittent porphyria. PCT is an iron-related porphyria caused by a deficiency of hepatic UROD activity, either via familial inheritance in an autosomal dominant fashion or as an acquired disease. It occurs in the 4th to 5th decade of life, commonly in men, and results in fluid-filled vesicles that develop on the back of the hands, as well as facial hirsutism in women. It is strongly associated with excess alcohol use and smoking, possibly from oxidative stress in the liver and the induction of cytochrome enzymes that utilize heme. Estrogen use, hepatitis C infection, and exposure to certain halogenated chemicals are other precipitants. The diagnosis of PCT is confirmed by finding substantial elevations of uroporphyrin in the urine, as well as DNA studies that show deficiency in the UROD enzyme. Treatment is highly effective and includes eliminating precipitants, phlebotomy or bloodletting, and a low-dose regimen of the antimalarial drug hydroxychloroquine. Acute intermittent porphyria, on the other hand, is the most common of porphyrias. It manifests as acute attacks of abdominal and chest pain, as well as dark or red fluorescent urine in young women due to a partial deficiency of the PBG deaminase enzyme. Recurrent attacks can damage liver cells, thereby increasing the risk of hepatocellular carcinoma by up to 70 times. Diagnosis is revealed by an elevated urinary PBG concentration. Treatment often requires immediate hospitalization to correct electrolyte derangements, narcotics and other analgesics, antiemetics, hydration, carbohydrate loading, and IV heme, a heme analog. In conclusion, porphyrias are rare but potentially devastating hematological diseases that are hard to diagnose but are often treatable. We hope that this short video has been useful to you, igniting your curiosity and conversation about the disease.